series in partnership with Business Expert Press. The co-editors of those book series are Jim Sporer, who I think is on the call, and Dr. Haluk Demirkan. And there's definitely opportunity for all of you if you'd like to author a book or co-author a book to check out that website and make a proposal to our esteemed co-editors. We do have a LinkedIn group as well as this community on LinkedIn. If you search International Society of Service Innovation Professionals, I encourage you all to do that. I don't want to take more time. And just check out issip.org at the website isip.org. Or you can reach out to me. My email is Yassi, YASSI, @isip.org. Susan?
Thank you so much, Yassi. I've actually put the link to the LinkedIn group in the chat. You may want to add some other items to the Zoom chat if you know,
sure,
some of the things you referenced.
Sure.
That would be fantastic. Okay, so I think we're ready to get started. And so I actually did start recording already during your session, during your speaking, Yassi. So, okay. So thank you so much, Yassi. And I'm just about to hand over to Farah. And let me do that. I will stop sharing. And over to you, Farah.
Full screen now.
It's perfect.
Excellent. So to begin with, okay. So can you see the slides when I do this?
Very clearly.
Okay, excellent. So good afternoon, everyone. Good afternoon from Oxford in the United Kingdom. And thank you so much, Susan, for hosting me today. So my name is Farah Shamout. I'm a second-year PhD student in biomedical engineering at the University of Oxford. And I completed my bachelor in computer engineering at New York University, Abu Dhabi. So my research mainly focuses on predicting clinical deterioration on hospital wards using machine learning applications with electronic health records. And in general, I'm just very passionate about digital health and the intersection of health and technology. So in this talk, it's going to be high level about what it's like to work in the field of machine learning in healthcare, with some projects highlighting the achievements in the field and practical implications and examples of research projects. So the first thing that would come to my mind whenever I want to introduce machine learning in healthcare is the number of data sources in healthcare. Now, traditionally, when we used to visit a clinician, the doctor would ask for age, family history, x-rays, symptoms, prescriptions, maybe eating habits, consumption of smoking or alcohol, and so on. And those are all different types of data. Now, when you're admitted into a hospital, there's also your vital signs that are recorded, whether that's in paper charts or in electronic health records now. Now, the use of paper charts began in 1907, and the first electronic medical records were introduced in the 1970s. But you'd be surprised that actually the picture of this paper chart on this slide was actually just 4 years ago in a hospital in the UK. So even though electronic health records are developing rapidly, there's the distribution of their implementation is still not fully implemented. In addition to those traditional data sources, there are also now more unconventional types of data that are becoming increasingly more accessible. So, for example, we can sequence our DNA more cheaply and efficiently now, and we can even collect data at home through wearables, and so on. So, my research focus is mainly motivated by the digitization of those data sources, and it focuses on two main pillars. One is personalized patient time series modeling and developing models that are specific to the patient and the subgroup that the patient belongs to. And second of all, the detection of clinical deterioration through fully predictive means, which means predicting whether the patient will face a bad outcome 24 hours or 36 hours in advance, rather than predicting it while it's occurring. So before I get into that, so clinical deterioration in general incurs very high costs on the healthcare settings, and health professionals in general are always working within very tight schedules. They're overburdened. So not processing the data efficiently causes even longer hospital stays, wasted staff time, and high burden on everyone involved within a clinical setting, both the patient and the professional. So I'm working with a data set called the Haven database, which stands for Hospital-Wide Alerting via Electronic Notice Board. And this is a project that has been established in Oxford, and is a collaboration between Oxford and the University of Portsmouth. And they're including data from several hospitals in Oxford and a hospital in Portsmouth. So I received access to that database for research purposes, and I'm investigating two detection approaches. One are the traditional methods, so early warning scores, which are currently being employed in hospitals anyway. So in the United Kingdom, we use the National Early Warning Score. I'll get into them in a bit. And the second types of methods that I'm interested in are the machine learning methods. I specifically work with Bayesian methods and deep learning. So what is clinical deterioration? So there are many different definitions, and it depends on the application that you're looking at and the way you define clinical deterioration. But the way I look at it in my research is trying to avoid preventable adverse events, such that the event could have been avoided if the data was processed efficiently prior to the event happening. So the examples of commonly assessed preventable adverse events include unplanned ICU admission, cardiac arrest, mortality, sepsis, and so on. And in order to assess clinical deterioration prior to a preventable adverse event happening, we try to examine three levels of factors. One is disease-related factors, so how severe is the disease, what's the rate of progression, what interventions has the patient been through, such as through medication or surgery. The second level of factors is patient-related factors, so the demographics of the patient, lifestyle factors, and finally the organizational factors, so the type of the hospital, which ward the patient is staying in, or seasonal factors like time of the day or time of the year, and so on. So the database that I mentioned that I'm working with is the Haven database. So in comparison to previous studies, we actually have a really large data set with over 700,000 patient admissions. And we look at patient admissions as independent patient episodes. So one patient may actually have multiple patient admissions. Now, electronic health records, so they basically contain all of the information that is relevant to the patient's stay, and they would contain like vital signs, medications, ward transfers, any interventions, pathological data, demographics, and so on. And like any other type of data within the data science and machine learning community, electronic health records do have their challenges. So one, they're complex, so they contain different types of data. Some are numerical, some are categorical. There's time series data, for instance. Second, they may often be incomplete due to the nature of the health settings. And depending on the electronic health record system that's used to collect the data. Third, the recorded data may be incorrect. So if it was recorded by a human being, this would, let's say, they may enter physiologically incorrect data at some times. And finally, currency. So we investigate currency in the sense that was the data recorded within correct periods, reasonable periods of time. So for example, in some cases, data cases, the discharge date would be prior to the admission date, which means there's something wrong in that specific observation set. Or the date of death is recorded prior to the conclusion of some vital signs observations. And this may simply mean that in the hospital, they input the date of death as the midnight of the time of that specific date or day. And so some vital signs may be recorded after. So those types of, those dimensions of the data needs to be assessed prior to processing the data. And there are some considerations that need to be taken that are specific to healthcare data. Now, preparation of the data set. This really relies on the application that you're looking into. And there has been some approaches that have been adopted in clinical practice and based on clinical expertise. So in some applications, I can simply use the raw data as it is with some data cleaning, of course. In other applications, we try to get data summaries from the variables, so we can derive parameters like mean arterial pressure, or even get statistical measures, so like minimum and maximum values of of systolic blood pressure, mean, standard deviation, and so on. And the third type of features are time series features, and those have to do with the analysis of some waveform like ECG data. And this also depends on what's being recorded in the hospital's electronic health system. So this is just an example.
Do you want to take a couple of questions, Farah, just briefly?
Yeah, of course.
Yep. Well, one says, can this strategy and model be used to anticipate and prevent infectious epidemics inside and outside hospitals?
Mm-hmm. So it depends on the model that you're speaking on. If so, infections within hospitals is actually a very hot area because they do happen, and they have to do with the environment itself. And there's one project that I'm gonna introduce in the end where they actually record footage of images of like clinicians washing their hands, and they analyze that to actually see whether their hands have been cleaned well enough or not. But if the model was developed for infections in the hospital, that's very different from a model that's developed for infections outside the hospital. So it really depends on the application. The models that I'm working on do not look at infectious disease. We look at general hospital outcomes like cardiac arrest, unplanned ICU admission, mortality, and so on. So it really depends on the outcome that you're looking at, the type of data that you're working on, and the setting of the problem.
Thank you, Farah. The other question is there a scrubbed HIMSS data set to the public?
A what, sorry?
Scrubbed, a cleaned up HIMSS, HIMSS data set available to the public?
So there's, so HIMSS here stands for the International Standards Organization that defines electronic health records. But there are some public data sets like MIMIC. So MIMIC is compiled by a lab in MIT, and it actually has data of patients who were admitted into ICU. The Haven database that I work with is not public yet. It's only accessible for research by University of Oxford labs.
Thank you. Please proceed because we only have 15 minutes. Thank you so much.
Okay. So this is a snapshot of patient admission, which shows like the vital signs, how they change over time. And then this patient, for example, was admitted into ICU at some point. So using the vital sign data, we actually try to predict whether the patient will be admitted into ICU or will experience unexpected cardiac arrest 24 hours in advance or 36 hours in advance. So when working with electronic health records, preparing the data is usually in a 3-step process, very briefly. The first one would be to clearly define what your patient cohort is by setting the inclusion and exclusion criteria. So for example, will I eliminate emergency patients, or will I eliminate surgical patients, or will I eliminate patients of a specific disease type? So all of those considerations need to be taken into account depending on the application. The second step would be to clean the data. So for example, to look for implausible values, to deal with missingness, and dealing with missingness has multiple different approaches that can be used. So some people adopt a complete case analysis where if any value is missing, they discard the observation set completely. Other approaches include imputing the population mean or median. Some research groups prefer carrying the previous value forward or the most recent value forward. And then there are other methods like weighted k-nearest neighbor methods, increasingly autoencoders if you're more on the machine learning side, to actually compress your features prior to processing them, and Gaussian processes, which I prefer working with because it's very robust. So it really depends on how you want to deal with missingness in your data set. And there are many studies that actually compare the different approaches. The second thing would be like when patients have different lengths of stays, how do you deal with that? Fusing different data types, analyzing the effects of interventions like procedures or medication, and finally, for example, in my project, if I'm trying to predict an outcome, how do I deal with patients who have multiple outcomes? And sometimes I just look at the first outcome and discard the data that occurs after that. So those are all different considerations that need to be taken into account. And finally, you can apply the methods that you want to look into. So early warning scores, those are the traditional methods, and there are numerous different types of early warning scores. And the objective is to do real-time alerting depending on the patient's vital signs. And the way they work is that they assign a score to every single vital sign, and then the total score is the sum of the individual vital sign scores, and the doctors get alerted based on how well the patient is doing. Now, the advantages of early warning scores, they're very easy to understand and implement. They relatively perform well. But the disadvantages is the many early warning scores are actually implemented on an individual hospital. So it's very difficult to generalize them to other hospitals. Most studies now just do validation on the same data set rather than on an independent data set from an external hospital. And early warning scores also don't take into account some of the patient-specific factors like age and sex and so on. And then there are the other branch, which is the machine learning methods, learning from retrospective data, and there are different approaches in dealing with that. Now, for early warning scores, the clinical research has actually shown that there are vital sign changes with age and sex. For example, premenopausal women have lower blood pressure than their male counterparts. And systolic blood pressure, it increases with age because the loading of the heart increases and the arteries thicken. So this is all on the clinical side of things. And this has motivated us to actually come up with an age and sex-specific early warning score, which has shown to be performing better than existing early warning scores, specifically for the younger population, because most of the existing early warning scores are actually developed on previous data sets that include patients above the age of 50 I would say. So this work is currently in review and will be published soon. Another project that I'm working on is more on the machine learning side, so doing predictive inference using vital sign data, and this involves using Gaussian processes to smoothen the data and then extracting the features into classification models, mainly deep learning models. And this has also been shown to perform better than early warning scores. Now, the third project that I'm beginning to work on is stroke prediction. So strokes are currently the second leading cause of death worldwide, and their burden of strokes is expected to double in the next 15 years. So the current objectives of this project is to actually build a screening tool that would assign a risk score to the patient, regardless of whether they were admitted into the hospital for the purposes of a stroke or not. And the second thing would be to distinguish between the different types of strokes. At the moment, stroke prediction tools only assess whether a patient is having a stroke on spot, so the patient can speak, or the individual, if that individual was at home, can speak, can't move their arm. This is how they're assessing stroke. But there isn't a tool that actually assesses strokes prospectively. So those are the three projects that I roughly work on for my PhD. But in general, if for a health-related project within data analytics and machine learning, it's really important to define the problem that you're trying to solve concisely, because I've been speaking to some health professionals and they keep being introduced to new technologies all the time, but sometimes the technologies are trying to solve a problem that's actually not their priority at the moment, or that's actually difficult to use. So it's really important to define who's the patient that you're trying to help. Where are you intervening? Is it at home, in the hospital, in the ICU, in public spaces, and so on? Now, I also wanted to briefly bring up some existing projects by other research groups. So the first one actually was introduced by our research lab. So this is the System for Electronic Notification and Documentation. It was developed in Oxford, and it basically replaces paper medical charts with a very simple and easy to use platform. So it's an iPad where the nurses and clinicians can input the data manually, and it's been implemented in our hospitals here and will be extended to other hospitals. Another interesting project which I found is depression management using self-reported data, and this only emphasizes the importance actually of self-reported data. It's certainly limited because there's a lot about having the patient to abide by actually inputting their data all the time, but it's a very promising field. There are other tools that are more diagnostic, so diagnosis of sleep apnea amongst children, for example. Apart from this project, I was actually involved in another one that also looks at sleep apnea amongst children. And by using very simple SVMs, support vector machines, we could actually outperform the existing very expensive sleep tests. The other one is early warning score for pregnant women. So this does more patient stratification and looks at pregnant women specifically. There are other projects that look at prevention. So this is the one that I mentioned a couple of minutes ago, which is intelligent hand hygiene using computer vision. So they actually analyze footage of how clinicians wash their hands to ensure that infections don't actually happen in the hospital, and real-time fall detection for elderly patients. So despite all of those projects, I believe that a successful healthcare project within this field has to do with its translation into a clinical setting. And to do that, the model needs to be one, generalizable, which is very difficult to achieve given that the data sets are very specific to a particular hospital or even region or country. The second thing would be the infrastructure. So if the infrastructure doesn't exist, what tools do we need to actually implement the solution? The third one, which is extremely important, is to investigate human factors approaches to actually ensure that the final product is easy to use by the health professionals, and that it's not just another wasted product or project that they're being introduced or thrown into. And this, of course, all feeds into just solving a real and relevant problem, not just solving a problem for the sake of applying some methods, and really keeping into account the clinical impact that a project would achieve. So that's it for now. I want to leave the last few minutes for questions. I hope this talk gives you a general overview of what I'm doing in the field. And if you have any questions or if you'd like to discuss potential collaborations or anything, please send me an email at any time. And thanks again, Susan, for hosting me.
Thank you so much, Farah. There are a couple of questions. One is any NLP unstructured text analytics also used on clinical notes, other free text? So that's one question.
Yes, it is. There are some projects that actually use NLP just to process the free text, because it's actually a very rich data source, because the clinician writes so much into the electronic health record of the patient. And yes, it is there.
Thank you. And then there's another one. How often is deterioration due to multiple drug interactions while in hospital?
So I haven't looked into that specifically, but the adverse events, a lot of the adverse events actually happen due to side effects of drugs. But this is not something that I look into specifically. I mainly look at general hospital outcomes like cardiac arrest and unplanned ICU admission.
Thank you. Thank you. Any more questions, anyone? And please also thank Farah in the chat if you enjoyed the talk. Any more questions? It looks like, oh, and leave your email address up there. That's a great screen to have. Yeah. So if people want to contact you. Okay, I don't see any more. Oops, I don't see. Oh, there's a question. Expanding on NLP unstructured text. Is there any value at listening and analyzing patient-doctor conversations and interactions beyond notes?
Mm-hmm. Certainly. Actually, so Susan and I met at the hackathon at NYU Abu Dhabi. And the hackathon theme is social good in the Arab world. And my team came up with an app that actually records and translates the conversation between the patient and the doctor. And there's a lot that goes in the conversation as well. One, to make sure that the patient understands what the doctor is saying, and seeing how that actually affects the patient trajectory after leaving the hospital. And second, for accountability. So even though the patient may experience an event outside the hospital, it also has to do with what the patient has experienced in the office with the doctor. So certainly, I think that would be a really cool project. I haven't seen any specifics working on that, but it has a lot of potential to actually analyze what goes on between the doctor and the patient.
That's very nice. I remember that project well at the hackathon. I should mention to the people on this call, the hackathon that we were at is quite an impressive one. It's been running annually for a few years, and the mentors and the winners, or even the participants from prior years, come and join in as well. And some of them formed companies out of what their hacks. And one company that was there had been in the hackathon 2 years before, and now they're featured in Forbes magazine as one of the most up-and-coming companies in cybersecurity. So who knows, Farah, maybe your team will be in Forbes magazine in a couple of years. Any more questions? Nope. Okay, well, thank you so much. I'll close the call, and looking forward to next week, where our talk will be about an adversarial toolkit dealing with adversarial attacks in deep learning. So thank you very much, everyone, and see you next week.
Thank you, Susan.
Thank you.